So welcome to today's Talks on Tuesday, Unseen but in Need, Identifying Girls with Autism and EI. And we're super excited to have Dr. Subarna Daria with us today. Before we get to her introduction, I just wanted to give you all a little bit of what to expect during this webinar today. We will be utilizing the chat, and it seems like everyone is used to using that feature. So feel free to keep dropping your name in the chat. And we'll also be utilizing a poll feature and the stamp feature, and we will give instructions when it comes to that time. Just so everyone knows, this is recorded and it will be posted and archived on our website. Also, the closed captions are on, and so if you need to access that, feel free to turn them on in your toolbar. You'll just go to More and Captions. My name is Lisa Terry. I'm an early intervention professional development consultant with the Virginia Early Intervention Professional Development Team. We also have Seth in the background, and he is doing a lot of the tech support. So if you need anything, feel free to message him if you're having any issues. And we also have Lorelei Pisha, who's new to our team if you haven't met her yet. And she's also just providing some background support. So welcome, and I'm going to go ahead and turn it over to you, Dr. Daria, and you can give your introduction.
Thank you so much, Lisa. Hi, everybody. It's really great to have so many people here and interested in this really important topic. Just a little background on who I am and my role. I am a pediatrician, and I've actually been working in Fairfax County's ITC or early intervention programs since 2009 at some capacity. And I've also had some different clinical roles, both as a pediatrician and also in developmental pediatrics. So I've been really fortunate to be able to support families in this program and more medically complex children, including having the capacity to diagnose autism early. You can go to the next slide. So we're going to start off by just asking a poll question, because just to see how relevant this topic is. And I'd love to hear how you guys, what you guys are seeing. So the first question is, how often are you seeing autism in boys? Are you concerned about autism in boys? And the second question is, how often are you concerned about autism in girls? I don't know about you guys, but in Fairfax, I feel like when we're going through our eligibilities right now, almost every other child looks like they have characteristics of autism. So it's becoming more and more prevalent in our system that we can see. So I wonder if that's similar to what you guys are seeing. I think I'll wait and see. Oh, okay. So I guess the poll is in. And in terms of the first question about how often you guys are concerned for autism in boys, I would say 8% said always, 69% often, and 22% said sometimes. And then in terms of girls, about 24% said often, and 62% said sometimes, 12% said rarely. So there is a difference clearly in gender when it comes to how often, at least it's a concern for us as early intervention professionals. So we can go to the next slide. And yeah, let's talk about what we'll discuss today. First, we're going to talk about what the actual prevalence of autism is in young children, and how it differs in between the two genders, how autism is diagnosed in both boys and girls, and what the consequences are for either not getting the diagnosis as early as it can be given, and what the difference is between those two genders. We're going to talk about how young girls present with autism and how it looks different than boys, and also a term that we use many times with girls on the spectrum called masking, and how that is important when we look at girls who might be presenting with signs of autism. We'll discuss some of the genetics and neuroanatomy of autism in girls specifically. And finally, just touch upon another topic of gender dysphoria and that prevalence in the population that we're talking about today. Okay, so let's start by just broadly speaking about how often autism is diagnosed. We know from the CDC data that the Centers for Disease Control, that 1 in 44 children, at least, or sorry, people right now are diagnosed with autism. And what you might not realize is within that number, it actually, when you split it up into genders, it's actually 1 in 34 boys that are diagnosed with autism and only 1 in 144 girls. That's a huge difference between boys and girls, right? So that kind of difference or ratio is at this point 4 to 1, in which we say that autism is really more predominantly diagnosed in boys. But when you actually look at real girls and their symptomatology, the ratio is probably closer to 2, from 4 to 1 to 2 to 1, of girls that should be diagnosed with autism but aren't. A lot of times there's like a gap, a 2-year gap between when the parents are concerned about autism and when they actually get diagnosed, or they don't get diagnosed at all until they're much older. So we can go to the next slide. I mean, the other things that are interesting to look at is when you look at the literature and look at the way girls are described or perceived, and what it takes to actually get an evaluation for a girl compared to a boy, it really sheds some light. These are just some quotes from some different research articles where they really discuss how girls tend to be overlooked. They really are labeled as shy or quiet. And so because of that, unless they're having significant behavior difficulties or cognitive deficits or really disruptive, they're really not going to be noticed enough, because they're just not demanding and not aggressive. So their characteristics look different than what we are all used to when we're looking at autism. Okay, so let's ask another question, and this one we can put in the chat. I'd love to hear from you guys. What clinical signs or behaviors do you look for that makes you concerned about autism when you're seeing a child in your program? I'd love to hear what you guys are seeing. Not engaged, for sure. So the lack of joint attention, the ability to regulate restrictive behaviors, sensory issues. You guys are saying some really great things. Rigidity, I saw, the eye contact, the atypical language like echolalia or language delay altogether. So yeah, I mean, you guys are talking about feeding behavior. Yeah, these are all really important things. Repetitive behaviors. some specific things about the feeding, like textures and things like that. And I see something about like that sleep issue. That's a big thing for me when I'm seeing a child too, actually. Um, so yeah, you guys have hit on a lot of different characteristics. Oh, difficulty with bowel movements. Interesting. So let's go to the next slide, and I want you to take a look at this, and I guess we're going to use the stamp for this. In terms of these 3 items, is there, along with the clinical signs, are there concerns from the families that they might bring up that might lead you to look into autism further? And then what about the use of standardized screens or tests? One of them that you guys might be familiar with that you use is the modified checklist for autism in toddlers, or the MCHAT. And we use something in our program called the POSI, or which is the parental observation of social interactions. But there's just different things, and I'm curious to see which sorts of which items make you or most helpful to you when you're thinking about autism.
If you bring your cursor up to the top of the screen, there should be a green bar that says you are viewing Lisa Terry's screen. To the right of that, there's a view options drop down. And if you press annotate, you should receive an annotation menu. There's a stamp button on that, and you can select your favorite stamp and then place it in the area that you'd like.
I see some stamps already. Definitely family concerns and clinical presentation are high up on this list, it seems. Some standardized testing is also important for people, but family concerns is really, really important as well, not just the clinical presentation. That's what I'm learning from you guys right now. Yeah, and somebody even said that the observation of a child and parent report give the most helpful information. So I think those 2 areas are top, of top importance.
And if we can just have everybody X out of the toolbar so we don't keep getting beautiful stamps on the next slides, and Seth will clear it. Thanks, Seth.
Okay, so let's talk a little bit about how autism is diagnosed. This is kind of important because one of the main tools or diagnostic assessments that is used is called the ADOS, or the Autism Diagnostic Observation Schedule. And that's kind of the most evidence-based method that we use. And it is, not the entire reason that someone would be diagnosed with autism, but it does hold a lot of weight. So the issue with the ADOS, though, is that it lacks gender norms, and in fact, probably racial norms as well. There is definitely a gender bias in terms of the cutoff scores that are used for this ADOS assessment. So it basically screens out the female phenotype in general. And if that's happening, and this is probably inclusive of a lot of the screening instruments that are used that we just talked about. If we use these sorts of things to try to figure out who is on the autism spectrum, then we can't include those people in studies, in research studies, because they are screened out. And so the research is done mostly on boys. And so the girls that are missed and that have more subtle characteristics and aren't included, they end up not learning more about how to include them within these studies. So it ends up becoming this kind of self-reinforcing cycle. And really what happens, what we need is specific scoring systems based on gender, or the level of nuance, the level of subtlety in the symptoms that are being presented. And that will help us to identify all of these children that are being missed. The other thing that I always think about is that clinicians who are diagnosing autism really need to not use these standardized tests so rigidly. They need to look at the whole child. As you said, we need to talk to the parents to get that family perspective. That's such an important piece of diagnosis, and looking at the functioning of the child. So all together, we can do a better job in identifying some of these girls, but we're not right now. So you can go to the next slide.
Before we go to the next slide, Dr. Daria, you had a question in the chat. Do you recommend not reporting if the girl did or didn't meet the cutoff score on the ADOS due to the bias?
No, I always do record the information, because when I do the ADOS, there's a lot of helpful information that comes from that, in which, just to describe how they are functioning in certain areas, whether it's how they direct attention to other people, how they are using their language, what kind of response they're having to joint attention. In many ways, I use the ADOS as a description of the child at this moment, and it still doesn't become the entirety of how I diagnose somebody. And I don't believe, that most people who are accustomed to seeing girls would do that, but I still think it's important to record that information somewhere, to make sure that it's available for the family as well. That's a good question. So the other thing that happens that makes diagnosis extra tricky for girls, especially as they're getting older, is that there are a lot of disorders that overlap autism, as you can see in this picture. This is from the Autism Internet modules, and you can see that they share a lot of traits with a bunch of different disorders. So they might be diagnosed with other conditions, but it might not be the entire picture. As you can see, if autism is part of this and they're not really, identified with that. So certainly comorbidity is common, and I would actually add another circle in these many circles of global developmental delay. That's something that we probably see more often in our population of younger girls. But nevertheless, it's really important to make sure that we don't minimize the autism diagnosis, because we are overemphasizing these other comorbidities. I don't know, was there another question before I go to the next thing? I can take a look here really quick.
I think just a statement.
Just a
more.
comment.
Mm-hmm.
Yeah, okay. All right. Why don't we?
There is a question that did just pop up when talking about comorbid. I can't even say it. Comorbidity. Have you experienced that one of the comorbidities is diagnosed more readily than ASD in girls?
Than autism? Well, so I can speak specifically for our population of younger children. I feel like a lot of times I have had actually this experience of another clinician in our community who diagnosed all of them with language delay and ADHD, which is in itself something that I really strongly disagree with, because ADHD really shouldn't be diagnosed this young in under 3 population. But the kind of combination of sensory processing disorder or ADHD and language delay or something like that tends to sometimes be a more prominent diagnosis. And the other thing I did not add to this as much, but there is that pragmatic or social communication disorder, which is kind of like an offshoot of autism spectrum disorder that sometimes is diagnosed. And in that particular diagnosis, we would see a lot of the social communication deficits, but without the repetitive and restricted behaviors, just to clarify that. Okay, so we know that these girls aren't being diagnosed as early as we like, or maybe not getting the diagnosis that's the most accurate because of other comorbidities being kind of overshadowing. And because of that, you know, we really need to think about the consequences. What happens to these girls as they get older when they're not identified as being autistic, but they continue to have all these negative consequences like social isolation, as social, you know, schema become more and more intricate and complicated as they become older and into adolescence, especially. Anxiety and depression. This is a very, very common thing that we see in young girls with autism as they get older. Rejection from their peers, even lower grades or academic, you know, issues. So these are all really, really crucial areas that are affected, even more so as compared to boys. So it's just such an incredibly important thing to identify as early as possible for families to understand how to support their daughters. Okay, so we know how vital it is to correctly identify these girls who have autism. And, you know, now I'd like to talk a little bit about how they present clinically. But before we do, one of the most common behaviors that you guys actually discussed when we were talking was repetitive behaviors. And so let's do a poll real quick and discuss girls and their repetitive interests. Which is a repetitive interest that you might see in a girl with autism? I can read them. Playing with certain dolls more often, but imaginatively, having a collection of rocks or shells, a strong interest in horses, or all of the above. And while you guys are doing that, I'm just taking a quick look at the chat here. Yes, social communication disorder can sometimes be missed. You're right. And sorry, I'm just trying to go up here. And watching maybe TV programs or using paper and pencil. Those are some other things that someone has written about. Okay, so the poll is in. 8% said playing with certain dolls more often, but imaginatively, is a repetitive interest that you might see. Having a collection of rocks or shells, 22% of you said that. A strong interest in horses, 8% of you said that, and 62% said all of the above. And yes, believe it or not, it is all of the above. And I think it's interesting because when you think about repetitive interests that are classically described, right? Like lining up toys, being obsessed with vehicles, or, you know, girls tend to have very much more typical sorts of interests. And even reading, I've heard this as a repetitive interest, where they read books repetitively, maybe in a more rigid way, but there might be less comprehension of what they're reading, of the content or abstract ideas. So the point of this exercise is to notice that the intensity and the rigidity in which they engage with these sorts of activities is precluding them from participating more fully with their peers and in activities that are social. So I think it's very different than what you might expect. And I think, yeah, somebody's talking about an obsession with books or musical theater. Yeah, you can think about just about anything that a lot of girls really like. And I'm speaking a lot about young girls right now, right? Like our toddlers. So it lends itself again for you to think about the fact that this is a reason that this is not so obvious to everybody, not to their parents, not even to us, because unless you really look carefully at how they might be using that activity to perhaps not engage as much, you might not realize or even consider it as a repetitive interest. So just something to think about. Okay. So we're going to talk a little bit about how boys and girls compare. And I'm going to give you an example of how you might see a little boy with autism and a little girl with autism in the playground, for example. So if you see that little boy hanging around in the playground, you might notice that he's probably maybe not talking to anybody. He may not have any language at all. He's probably separated from all the other boys that whatever they're doing, he's on his own. And he's also, maybe doing something unusual like picking up mulch or leaves and kind of like letting them fall and drop and watching his hands, watching the leaves fall, maybe taking a car and looking at the wheels, and he might be running a lot, being pretty active. But when you look at the little girl with autism in that same playground, she looks very different in this particular example. This little girl is probably very interested in being close to the other girls in the playground. So one, she has probably better language, so she's going to be able to talk to them. She might be parallel playing with them, so she might be close and looking like she's part of the group when she's not really part of the group. Or she might even try to participate in the play, but not really understand how or what's happening. As we said before, her restrictive interests are lower to begin with, but they also really look like what the other girls are playing. So it doesn't look very different. And the only thing that might be a little bit different for her is that she might be a little more active. But frankly, she's a young girl. And so who do you think the preschool teacher is going to notice, right? In this particular example, she's definitely going to see that this little boy looks different than his peers, but it's going to be difficult for that teacher to notice that little girl might have something going on. So, this is just like one example of being aware that some of these this ability for these little girls to imitate, to a need for her to fit in with some of her peers, and the fact that she has more typical interests are just, yet another reason that her diagnosis might be delayed. Okay. So one question that I had when I was reading some of these articles was that, so we know that young girls with autism might have higher cognitive abilities, right? They might have less intense symptoms and reduction of symptoms over time. That's what the literature says. But even in the girls that have the exact same symptoms and behaviors as boys and are cognitively impaired just the same as a boy might be, they are not being diagnosed with autism. So this was very interesting and confusing to me when looking at the research. We can't really pin the reasoning down to cognitive ability as why these girls aren't being identified. So let's go to the next slide, and we're going to talk a little bit about, you know, what questions now you guys usually ask to help determine whether a child you're working with might need an evaluation for autism. And this would be great to be something you write in the chat. If you have specific routines that you use to help give you information, or what kind of comparisons that you think are helpful or not helpful. If she has used language and then no longer does, that regression. Yes, that's a really important one. Turning to their name. So you're kind of watching that and asking about how they utilize those routines, how they play. Absolutely. Any aversions to sensory input, any sort of stereotypies, a speech delay, how they interact with other kids, right? Their siblings. If they're using scripts, yeah, if they can sustain play interactions. So these are some things that you guys are asking, right? Like if the parents notice rigidity, if they notice some differences in their transitions, how interested they are with screens versus people. And I can speak on toe walking. I mean, certainly when I see that, especially over the age of 2, I want to make sure that that there's not some other component besides a sensory component going on there. But it's definitely something we see for these little girls and boys, speaking in facts, but not necessarily conversationally. So yeah. So it's just kind of asking questions about what their language looks like and how they use it with other people, right? That's social pragmatics again. Very good, yeah. And sometimes repeating their language or how they use eye contact. Yes, this is a big one, right? How interested are they in the alphabets and numbers and shapes? I see that so much, whether they're boys or girls, right? Yeah. And I don't know about you guys, but yeah, I do see, I mean, parents are very proud of their children for being so academically focused, even at this very young age. And you don't want to take that away from them. We want them to feel pride in what their child is doing, but we also have to look at how they're utilizing language, like somebody said, functionally versus, you know, just to show what they know, or facts, like someone else used that term. Yeah, hyperlexia as well. So these are all really great things that you guys have put in the chat. Thank you. Yeah, so I'm going to now in the next 2 slides kind of talk a little bit more about the main clinical features that we see in girls with autism that distinguish them perhaps from boys and from their peers. So this first study was done in Canada in 2020, and it described what we call a female autism phenotype. And what's interesting about it is that there were certain behaviors that were not captured by standardized measures, like the ones we had just talked about, right? In the ADOS or some other standard assessment tools. And some of those included narrow interests, but typical for girls, kind of like how we just talked about that little girl in the playground. Higher social attention and language ability, motivation for social interaction, and then more ability to mask their behavior. And we're going to talk a little bit more about that in just a minute, but those specific behaviors are things that aren't being picked up when most clinicians are using a standard tool. So it's important to kind of consider these as other things to be paying attention to. So if we go to the next slide, these are, I was looking at a bunch of different studies looking at how toddlers might present. And a couple of interesting things that I found in some studies are that females with autism had greater motor deficits and less communication impairment to their male counterparts. So that's something to keep in mind, that they need, and this is something that won't surprise you after everything we've been talking about, but they need more social communication deficit as compared to a boy in order to even be referred for an evaluation. So even if they have a deficit in this area, it has to be a greater deficit, because even girls with the same symptoms aren't necessarily getting a diagnosis. Also, that girls were more likely than boys to use imitation to engage in a social interaction. And like we said before, they have an unusually strong desire to fit in with peers. So that's really stressful, I would say, probably for these girls. And that's going to lead into what we talk about in a minute. And finally, there is a concern for this externalizing behavior. This particular information was taken from an article from England, which is why it's spelled that way. But the reason for a parent to refer their child for further evaluation seemed to be more related to when their child was either, starting to be aggressive or self-injurious or have some sort of outward behavior to an adult. That's what kind of prompted that referral. That's what externalizing behavior really, is talking about. And finally, girls were really reported to be more likely to show obsessional interest with toys or seemingly random objects. One example I could think of, I've seen some different videos now of these little girls. I saw one where her interest was she had her blanket with her, which is a pretty typical thing, right, for a lot of little toddlers to have, but she kept sniffing it over and over again, maybe as a coping mechanism. I saw another little girl whose parents took her to the drugstore, and she walked over to a aisle of like little shaving cream bottles and took them all out and kind of lined them up on the floor. And I guess her parents did think that this was a little bit unusual, but these are just some examples of how little people, our toddlers here, tend to look in terms of their presentation, and specifically girls versus boys. So now this is a term that we have been kind of throwing around just recently, and I just wanted to know what people know about masking and what is masking. If anyone wants to type it into the chat, and more specifically, how does it apply to girls with autism? And we're going to talk about this, but I just was curious to see what you guys think. Learning social rules and imitating them. Yeah. Hiding, trying to blend in, changing the way you respond to fit in. Under the radar. Yep. Intentionally controlling their face to look quote unquote typical. I like that. Yeah. We're going to learn about it, so no worries. Suppressing behaviors. Yes. Yeah, these are all really great descriptions of really what masking is all about. So, and yes, absolutely, it creates this stress and anxiety, and that's kind of what I'm going to talk about next. So,
And Dr. Dari, I don't know if you saw this question. Is it typical for 4-year-old girls to be more sensitive and get upset easily on playground or during transitions at preschool? She's a twin and also walks on toes, or could it be ASD?
well, I would say transitions or difficulty with transitions is certainly something that is a behavior that we think about. Like when I think about little girls, I think about how rigid they can be about having things in their way, even if the things they're doing are beautiful. It's just kind of the way in which they need to have it done. That self-direction, so to speak. So transitions kind of speak to that level of rigidity. So that is a child that I would be concerned to just get further evaluation for, based on just that small bit of information. Oh, can we go back? Yeah, thank you. Okay. Yeah, so as you guys really amazingly pointed out already, so masking or camouflaging is essentially hiding symptoms that are, part of their identity, learning scripts, or imitating others without understanding social situations. And therefore, these girls are essentially flying under the radar, as someone else said too. This stress of masking, as someone also pointed out, it really can lead to a lot of the issues, that the negative consequences that we spoke about earlier, including depression and anxiety. And the other interesting point to this is when girls become so good at masking, and I will say this, it doesn't have to just be girls. I mean, I think that there are boys who might have some more subtle symptoms who might behave in this way too. And the point I want to make is that if a girl or a child is masking most of the time, one, when they get home from all of that work that they've been doing, they are exhausted. And they can really, all the stress that they've been kind of, um, you know, been under during the whole day, they kind of have to let it out somehow. And maybe that's something that I always think about, is like, how do they, act when they're at home and relaxed versus when they're out in public and they have to act a certain way, which is really unfortunate that they do have to feel that stress. And the other thing is, if they're taken into an evaluation and they're really good at masking, it might be difficult to recognize the symptoms or behaviors in order to make an accurate diagnosis. So that's yet another reason that that females who have autism, who have better communication skills, who have good nonverbal gesture use, they can demonstrate some of these camouflaging symptoms and show really less impairment during their assessment. And therefore, it's harder to diagnose them. And what age does masking typically start? I mean, I think it really depends on the environment the child is placed in and their level of language and social and gestural abilities, because if they're really good at imitation and if they have that strong desire to fit in with their peers, I'm sure that they can start when they're toddlers. That's just something that's, I think, individually based. I don't think I can give an age for that. But in you can go to the next slide. So I think in order to combat this need for masking, the movement, the neurodiversity movement that has luckily been much more predominant lately, we as I think society have to recognize the value of every person and the way their brain functions and the way they think is so important. And there are so many self-advocates that are, a part of this movement. I'm not going to go into great detail about this, but I think it's very important to remember that, we need to embrace every person without asking them to change, without making them try to fit in a typical way or normal way. It's the societal pressure that we might be putting on these young children can affect them much later in life, as we already talked about. And so, even though this is beyond the scope of today, I am going to touch upon this a little bit more next month when we do our part 2. And I know that in the resource list, there's a link for a great course from Vanderbilt that talks about neurodiversity in early childhood and early intervention. So if you're interested in learning more about it, I highly encourage you to look at that. Okay. So this part is probably some of my favorite stuff because I love to share some of the research around both genetics and anatomy of the brain as it relates to these young children. So the female protective effect is a hypothesis that suggests that children, or actually females, are protected from autism for unspecified reasons, but that these children who these young girls need to have a greater number of what we call a genetic hit to their DNA in order to gain a diagnosis of autism. That means, they need, more mutations or something abnormal going on in their genes in order for them to have a presentation of autism. And for that reason, a genetic consultation for these children, these girls, are especially important. Specifically, some of the other information that is in the research talks about how there's different types of gene disruption, right? Or things that can be inherited. So it turns out that there's a certain type of mutation, or copy number variance is a term that they use in this example. These particular ones are 3 times more likely to be identified in autistic females when compared to males. And there are loss of function mutations that seem to have a maternal transmission. So it seems like mothers are more likely to be carriers of such mutations than fathers. So for that reason, even when we do genetic testing for any child with autism, we do usually look at both the mother's DNA and the father's DNA as a comparison to see if it's coming from the parents or the parents' families. So it's not a complete reason to explain why less girls are diagnosed with autism, because as we talked about, this is multifactorial. We have a diagnosis bias, so to speak. But mothers seem to carry more risk than fathers of children with autism, at least according to some of the genetic studies that are available right now. And I think, genetics is going to continue to evolve, because the more we have children who get genetic testing, we're going to find more and more answers to what might be leading us to have this diagnosis to begin with. So we can go to the next slide.
Okay, before we do that, you did have a question. Is it true there is a high incidence of gender dysphoria in older autistic girls?
I'm going to talk about that. I promise I won't I won't forget at the end of this discussion, because that is definitely a very important topic. And yeah, it's a very a large population of those with autism who have gender dysphoria. So the other thing I wanted to speak a little bit about is the neuroanatomy. There was a study done in 2 to 5-year-olds, and both boys and girls seemed to show enlargement of their brain matter. But it seemed that girls additionally had a significant enlargement of their temporal gray matter volumes and a reduction of the cerebellum gray matter. And these seem to affect their motor functioning and social regions of the brain. And this kind of goes along a little bit with some of the research that we talked about earlier in terms of, that girls might have more motor deficits than boys. Additionally, the way that the functional brain organization occurred for girls versus boys seems to point to how or why there's a reduced amount of restricted and repetitive behaviors in girls versus boys. So the other piece that's another interesting finding that was in an article was that the pattern of the abnormality of the brain that they saw in these younger girls of 2 to 5 years old was actually very similar to adolescent boys with autism. And that kind of suggested to us, to our community here, that the onset and timing of the pathology that we see might actually be earlier in girls. Finally, seems like, there's a promotion of myelination, or the myelin sheets on the nerves in the brain, and that somehow that kind of leads to a more severe profile of this sort of anatomical abnormality. So all of this, I think, leads us to understand that this truly is a neurodevelopmental disorder. There's a reason we call it that. And maybe further research can help us to understand how to target treatment even more specifically for girls. Okay. And now, finally, I really want to talk a little bit about the social brain. So the social brain isn't just one area of the brain, right? It's an interconnected set of different regions that are kind of talking to one another to help a person understand what's going on socially, whether it's the face processing, fusiform gyrus, the amygdala, which is the emotion hub. And then there's also the superior temporal sulcus that tracks people's attention and movements. So all of these kind of play a role to helping us understand what's going on socially in our world. So when they did this study at looking at this compared to boys and girls, they found that, not that surprisingly, typical girls have the most active social brains, and boys with autism have the least active social brains. But typical boys tie with girls with autism somewhere in the middle. And that's pretty amazing when you think about it. What's interesting is that these girls with autism, even though their social brain seems to be working, it's communicating with their prefrontal cortex. And as you guys might know, the prefrontal cortex is the area that engages with reasoning and planning. And it basically is intellectualizing how to socialize. So these poor girls are burning through all their energy just trying to be in that social circle with other peers, with other women. But it's, instead of it being intuitive as it would be for a woman without autism, they are using all of their brain and the most kind of like intellectualizing part of their brain to figure out how to socialize. So I just think that that's really fascinating for us to understand that even though they look the same as a typical boy, they are working so hard to look that way. So as our final chat question, we just wanted to find out what you thought was most interesting about some of the information that we're presenting about genetics, about neuroanatomy. Is there anything you want to learn more about, or you wish there was more research about? So that's kind of, I'm interested to hear what kind of resonated with you.
And Dr. Daria, there was a question about the article too. I can't remember. The link wasn't in the handout, correct? So
The link wasn't in the handout?
was it in the handout or was it not? Do you remember? I can't
It should
remember.
be.
Okay, so Koya, the link might be in the handout, and if not, feel free to email me.
Yeah, that typical boys kind of tied with autistic girls. Yeah, the social interactions and the intellectual social skills. That's a good way of putting it. Yeah, yeah. I also find that fascinating. Yeah, it's always want more information and research on that, on the brain. It's true. Yeah. So I think I'm, hopefully that there's going to be a ton more research coming in the future. So this last piece here, as I said, I wanted to touch upon was the fact that, gender dysphoria is, first of all, is a condition where a person experiences distress or discomfort because there's a mismatch between their biological sex that's assigned at birth and their gender identity. And believe it or not, 1 in 8 autistic people live with gender dysphoria. So that's, as you see, over 7 times more likely than the general population. And this can actually happen as early as 2 years of age. They can start to have these feelings. So this is not something that you won't ever come across, even in our early intervention population. So I just think, given the idea that there's this higher rate of dysphoria with those with autism, and that there's co-occurring mental health conditions with both autism and gender identity disorders, we really need to be paying attention and listening and looking for the fact that this might be in some of the children that we treat. So just to summarize, as we talked about in detail, girls present differently and they're not diagnosed as early. There's differences in the way their genetics might look, as well as their brain structure and function. And finally, gender identity disorder is much more common in this population. So it's important to keep an open mind about that.
Thank you, Dr. Daria. That was so great and so full of just fascinating information. If you have questions, feel free to type them into chat. I'm going to go ahead and give you instructions for the survey and the certificate, but stay tuned for the next talks on Tuesday. Because you're registered today, you're automatically registered for the April session. And check your email after this, take the survey, and once you take the survey, you can download the certificate for the talks on Tuesday. So thank you all for being here, and we can answer any questions. I know there was a question, Dr. Daria, on ideas on how to support our families that are moving to Part B that are tricky ASD kids.
So I will be touching on this next month. That's something that we're going to be talking about. So definitely stay tuned for that. But in general, my guidance is always, talk about it early. Even if they don't have, behaviors that might be as obvious right now, at least putting it on the parents' radar and, you know, helping to encourage them to advocate for their child and in what they need. It's just important to kind of reduce that stigma as much as possible.
And people are asking about the recording. Yes, the recording will be available on the VEIPD Talks on Tuesday topics tab. So, or I'm sorry, not the topics tab, but if you go to the learning, then you'll see the Talks on Tuesday and you can check it out there. There's also a question, what would I see in a toddler with gender dysphoria?
Well, I think in general, these children might just look like they play with different toys than maybe their typical peers in that same gender, or they might, you know, want to dress a certain way that's different from another child in that same gender. I think as they get more language, it might become more apparent based on what they tell their parents. And again, this is something that it might be very, very early, but it's just, we just want to make sure that we destigmatize that for families and parents so that they don't feel like there's anything wrong with their child.
Thank you. Not sure if you'll give thoughts on a specific example, 8-9-month-old that has no interest in transferring to another position, have to really motivate her to roll and basically move, great eye contact and smiles, barely ever laughs.
That's pretty early, 8-9-month-old. I mean, I would still probably follow that little one and see how they progress. If they start to, you know, show gesture use and pointing and all of those things, I think that will give you some guidance. But then the environment is also important, right? Like whatever they're exposed to and what's available to them. But yeah, I think I would probably still be watching that one and without necessarily thinking about autism quite yet.
Okay, yeah, she said mom was asking and I hated to guide one way or another at this point. So thanks for your thoughts. All right, well, thank you everyone. It looks like somebody just mentioned they'd like more info regarding treatment such as ABA and relational based therapies too. So I don't know if you're touching on that next month or not.
I'm not necessarily talking about ABA at this point, just because we're really focused on what's happening in early intervention. But I would say that there's some naturalistic developmental behavior interventions, NDBI, that I would look into that kind of gives you the best of both worlds of looking at the developmental intervention and behavioral intervention, especially for these young children. And that's probably the route I would take with a lot of these kids.
Great. You're getting so many kudos in the chat. This was really great. It sounds like everyone really enjoyed your presentation. So thank you again, Dr. Daria. And I hope everyone has a fantastic day. Thank you.